Thank you. Go by my middle name, Stana, and I'm up front. I'm going to let y'all know if you want to get hold of me afterwards. It's firstname.lastname@us.af.mil. There's all sorts of notes in the bottom of the PowerPoint because I wasn't quite sure how this would play out. And I know we got med students out here, and we've got folks who, like me, were trained back in the day when even an internist could do neurosurgical procedures in burr holes, and there was no ER medicine, and I might have liberated a few ultrasound machines to use for various reasons. So all of that fits quite nicely in with the concept of MacGyver, I guess. I am an internal medicine, aerospace medicine, occupational medicine, formerly critical care doc, and global health assistant professor. I joined after 9/11 as an Air Force flight surgeon, supported OEF, OIF in Iraq, Afghanistan, Southwest Asia, Kuwait. I'm sure I'm forgetting some places, was special ops as well. So I'm very pleased to be here and was really impressed with the previous discussion. Again, if any of that also touches on questions you might have, please feel free and reach out to me. 1,000, 2, 1,000, 3, 1,000. 7 seconds, we were ordered. I have nothing to disclose. I'm here on permissive TDY because this matters. All right, so this is the overview. Those of y'all in the military know we got to talk about what we're going to talk about, and then ask if we've summarized it well enough. So we'll touch on Space Force and Space Command missions. I was really happy to hear what Dr. Peterson talked about with aerospace medicine. I also was fortunate to get to hang out with some NATO space medicine folks a couple months ago, and they're on the same track and thinking as those of y'all here. And then hopefully I won't blow up some of the ideas, but there is puffy-faced chicken leg on orbit, so the idea of intracerebral pressure takes on a whole new meaning, and 20-some seconds of parabolic flight I'm pretty sure doesn't tell us what we need to know. Then there's just the practicality, and I too have that picture from the internet at the end. This isn't, can you make the volume?
Military operations. Our daily lives and our national security depend on safe, stable space operations. Imagine a day without GPS, cell phones, ATMs, credit cards. Imagine our munitions go off course, secure communications are lost, drones are grounded, maneuverability on ground, sea, and air are disrupted. The United States' ability to multidimensionally project and employ national power is predicated on access to space and space superiority. The United States Space Force Guardians are our sentinels, securing the multi-domain battle space, operating 24 hours a day, 7 days a week. The Air Force Medical Service readies the Guardian warfighter for their critical missions. Our Guardian warfighters must be medically ready, reliable, and capable. Indeed, the AFMS has been there since the beginning of humanity's aerospace adventure. Flight surgeons, physiologists, physical therapists, bioenvironmental engineers, and behavioral health airmen have ensured the mission into and from space for 75 years. We coordinate human spaceflight support, rescue, contingency operations. We ensure Guardian readiness and space launch Delta operations. We are building the next generation of aerospace medicine experts, innovating human performance readiness solutions for scenarios that push the limits of imagination and delivering trusted care anytime, anywhere. As we embark in a great power competition with near-peer competitors in space, we continue to innovate, recruit, and enhance our assets, including our human weapons system, and we work with our allied academic and industry partners to maintain space superiority. This is our privilege. This is our challenge. We own the high ground. We are the world's elite medical service in air and space. We are the Air Force Medical Service.
So I had to do a little plug. As background, right, the Space Force stood up 20 December of 2019. I had been fortunate to be a Johnson Space Center Air Force liaison officer for 2 years. I became mission certified on console to support station, shuttle, and EVAs. And during that time, we actually reconfigured the space station and space shuttle based on physiologic notions that some astronauts had come up with. The Space Force Medical Operations Directorate was officially established on 10 March of 2023. So it only took like 15 years to talent manage me back into a space type of role. What is important, and for the young folks out there, the med students at USIS and whatnot, is a lot of what has to be thought of as how we would approach surgery in space and surgical support to human space flight requires that broad understanding that you all are going to get when you're conceptualizing the issues that were previously just discussed with Ukraine, that concept of austere medicine. And austere medicine doesn't have to be in a desert somewhere, right? Austere medicine can be next door if you can't get the stuff that you need. And then you've got to be creative, right, and liberate things. So that goes to what Dr. Peterson was talking about. Aerospace medicine is a foundational concept. If we're going to support human space flight, part of that for us in the Space Force, as you can see here, as we're supporting the Space Force, requires that we have medically ready guardians, and that they're optimized to perform their duties. Their responsibilities are to deter conflict, to have space superiority in support of our national security strategy directives, because space is critical to our everyday lives, right? What we're doing here, using computers, how we all got here with GPS, the ATM we hit up, the gas station that we used, all of it stops working if we do not have space superiority and security. So the NATO Space Medicine Working Group also hit on these tenets as well. The NATO nations are looking at aerospace medicine as foundational to space medicine, and then having the, we're in agreement that other specialties like surgical medicine, ER medicine, et cetera, once they have that aerospace medicine and human systems integration understanding, which you can have, and there's a slide coming up with a bunch of links to NASA standards, NASA realized that if we're going to move into this next level of commercial space and space exploration, we got to get everybody up to speed, and we can't hold on to data. We need to collaborate and coordinate on and prioritize on things that really matter, as opposed to what I call pigs in space, right? Since I started my job, we've had lots of really enthusiastic people who want to intubate pigs and stick them in a centrifuge and see what will happen. I know what will happen. It will be really gross, and it will really not inform what we need to know. But I'm sure someone will fund it, so yay. So the NATO folks as well are thinking about the foundation. Part of that also requires then that the physicians that are interested in this also have the right attitude. It touched on it a little bit, right? It's sort of what makes a good special ops person, what makes a good NGO, Doctors Without Borders person, what makes a good person who is going to support space flight, either in contingency response when we have to go scoop them up, Navy, shout out, right, and bring them on shipboard to take care of them. You probably should have an understanding of what that person went through, about their bone density changes, the fact that they grew in space, that they went from having puffy-faced chicken legs to now being volume depleted, even though they probably, did take all the volume resuscitation prior to landing. It will matter when you when you treat them, right? If you don't understand that baseline, you will do something that harms the patient, which we don't want to do. We touched on the bits there of particular import right now for y'all's awareness. We're already supporting a 300% increase in launch. The Space Force is organized slightly different than our Air Force. They have space-based deltas and space launch deltas, and there are guardians all over the world in EUCOM and in all of the locations that y'all will interact with. And that then brings with it a tale of understanding bioenvironmental engineering, public health, et cetera. So this is already outdated. The other thing that the military often does, right, and gets called upon to do, whether you're an internist, ER doc, surgeon, et cetera, is support something that goes wrong. So what could go wrong, right? These are the already outdated locations of orbital and suborbital launch sites in the world. There's already some extra here. When something goes awry, they will call us up to scoop someone up and do something about it. So we touched a little bit about the fact that spaceflight is expensive, and some of the articles out there are really cool about creating a means of doing endoscopic or minimally invasive surgery or whatnot, and what the packs look like on orbit. At Johnson Space Center, when you're training the astronauts, you actually go with them to the Herman ER, and they see the stuff that comes through the Herman ER, and they learn how to suture, they learn how to cath themselves or their friend, because there are issues on orbit. The issues that we actually do see on orbit don't tend to be things like chest pain. They have been skin issues. They've been UTIs. The astronauts call it GI awareness, right? Meaning they all want to throw up at some point. And then just getting used to which way is up, right? Wherever your chin is. So knock on fake wood here, in the age of spaceflight, and there's a link for that too in the sections, you can see that things go wrong almost every day, and things have gone wrong on Apollo, Soyuz, Skylab, et cetera, and fortunately not surgical issues. But we are due, right? So that's the other thing. When you look at these risks, I feel being somewhat faithful is important. The Apollo 1, Challenger, and Columbia tragedies happened, and so we are due for something to happen. You can see how long it takes to evacuate folks. In-mission medical care becomes very important. You can, that's dependent on comms, though, on useful comms. And again, you can even teach a flea how to do some surgical stuff. So astronauts are pretty smart, probably smarter than me. And so we can teach them how to do it, but if there's a delay, that's not very helpful. And then from a military perspective too, right? If you're teaching somebody who's not used to doing something, a task, and it doesn't go quite right, then you've got to deal with the behavioral health outcomes of that, right? Which goes into screening, standards, et cetera, all of which we're thinking about what needs to be done both for human spaceflight and controllers. And we're also working on baseline educational U.S. Spacecom. So Space Force trains, organizes, and equips personnel to present to combatant commands. U.S. Spacecom is a combatant command. So they are the forces that generate an impact, if you will. So they have put onto a military, it's on JKO, a module, and we're going to add modules to it. Their modules have to do with recovering someone, so what the PJs or Navy might do, or if an air evac is needed to pick somebody up afterwards. And I love the fact that there's no TJC in this arena, which means there's no DAJ in this arena. So y'all who have worked with them will get that. I see a little smile. All right. So the idea of being, so what NASA will tell you is everything they do is off-label, right? They have not gotten to a point where they are going to do randomized double-blind control study to figure out, like what we did, which is reconfigure the space station and space shuttle. They, when you're prepping for a TJC event, right, you're making sure infection control, et cetera, is well done. They are doing that to the nth degree, right? Everything is swabbed. They've got biocides. They've got all sorts of things that have to be considered. We touched on the Vomit Comet, and we touched on MacGyver. Okay, so something that I think is interesting, and again touched on, related to what Dr. Peterson said, is when we are thinking about surgical procedures and or how we can get at a surgical solution, a really neat thing that is also on the web that NASA put out there is, aside from the NASA standards, there's tech orders and whatnot, and there's a human systems integration workbook. And this will give you an idea of some of the things that that we've had to go through to figure out whether or not something is going to be airworthy and the repercussions therein, right? So if you're going to infuse some sort of object that allows you to perform surgery with 100 millimeters of mercury of pressure, that's going to affect the environment, and you got to find a way to mitigate that. If you're going to push out 1 liter per minute of fluids, they only squirt out like 250 cc's of water at a time on the space station. So how are you going to deal with that? How are you going to deal with the energy requirements? Where are you going to get that water from? And how are you going to isolate it from the rest of the station, right? So if even the workout equipment is isolated, because if you do a squat, you could make the space station move, it is conceivable that some of these this equipment could also generate motion. And this just touches on the NATO discussion that we had. If folks want to take a picture. And yes, I had the same picture out there. But leveraging everything that you all have done and can conceptualize and then flipping it on its head, right, I think is the most important way of looking at how we're going to get at subserving commercial space's idea of requiring space surgery, right? So right now we've got flight surgeons who take care of healthy people in unhealthy environments. We are now in the realm of unhealthy people in unhealthy environments. What could go wrong? So if there's nothing else, I'll take questions.